how many people are able to join us this morning. I hope other people are able to use the link that was just sent out. So welcome. Hi, Hiba. It's very nice to see you as well. Okay, people are still joining. I'd just like to welcome everybody on behalf of Women in Health Together for the Future. I am Judy Lewis. I'm the board chair, and it is always a pleasure to see all of you, members and new people who we hope will join us. So I'd like to say good morning, good afternoon, and good evening to all of you. And I hope you're enjoying the warmth and cold wherever you are. Briefly, for those of you who are new, we are an organization of academics and advocates and students and community organizations working to improve women's health around the world. And this webinar this morning is part of our series on closing the gap in women's health, which we started last spring. And we are very looking forward to hearing from Dr. Ayat Abu Agla, who is going to be talking to us about policy issues. That is like the fourth root cause of the gap. The first one being data, the second one being science, the third one being um, investment, and the fourth one being policy. So we are very much looking forward to this. We hope to have a very stimulating presentation followed by a discussion, and we really would like everyone to be able to participate, which is why we have all of these screens on. So I welcome you. I invite you to join us if you're not already a member. I'm going to introduce Professor Mohammed Mukir, who is a founding board member of WHTF and a longtime participant in all of our activities. He is currently on the faculty at, just a minute, because he's moved around a lot. He's been at Maastricht, he's been in many places, he's been a consultant to many different organizations. And he is now back at Afad University, which is where he was when I first met him quite a few years ago. Mohammed, we welcome you and ask you to introduce the session and Dr. Abu Agla.
Thank you, Judy. Hi, everyone. Good afternoon, good morning, good evening. It is my pleasure today to introduce Dr. Ayat Abu Agla. Dr. Ayat Abu Agla is a medical doctor with PhD in global health from Trinity University in Ireland. She is a consultant in community as a community physician, public health specialist, and implementation research scientist. Dr. Abu Agla, she currently works at University of Birmingham, where she is leading the Health Service Management Center at Dubai. She is also a co-founder and director of the Health System Research Center and also the MSC Global Health System, which I think will be launched in January 2025, which is a very wonderful news that there is something going on with global health. Dr. Ayat has a cooperation with many organizations and UN organizations, especially with WHO, EMRO, and she's a member of many working groups around the world. With her more than 18 years experiences and expertise in academic and research and policy, based on all these experiences and expertise, we are honored at Women and Health Together for Future to have Dr. Ayat Abu Agla today for this important webinar. Also, I am very proud of Dr. Ayat. She was one of my students at Ahfad University a long time ago. So, Dr. Ayat, you are welcome, and the floor is yours.
So thank you very much. It's very kind of you. Dr. Mukhayyar, and it's always a pleasure being reconnected with former professors, colleagues within WHTF, and absolutely Ahfad University for Women, for which I was a graduate, a very proud graduate, I must say. So, without further ado, I'd like to again welcome you all to this session today and hope that together we can continue the discussions when it comes to bridging just health systems in this era of polycrisis and looking into bridging the gender gap. Within ourselves, the participants with us here today, how would you define health systems? I thought to start about that because even within our respective institutions, within our respective countries, indeed how each of us defines health systems will differ, and will also differ if we are at the supply or demand side. Another question to the participants with us here today is, where do you situate yourself within health systems? So where do you see yourself within that specific area? Do you play interchangeable roles within our health system? For example, I'm a medical doctor by profession, so I can situate myself within the supply side of the health system. However, within the demand side, if I'm a patient, if I'm a co-patient, then I'm on the other side of the health system itself. So, leading on and building on how we define health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So we can see that within our health itself and the definition of health, there are many interacting factors, and within the systems that define health, defining a system as any collection of related parts that interact. So our health systems are as complex, not complicated, not simple, but as complex as systems go with their interchangeable building blocks. So health system is indeed defined as all organizations, institutions, and people, resources, and actions whose primary intent is to promote, restore, or maintain health within our health systems. And with respect, as I had already mentioned, to where you're situated, how you define your health system, primary, secondary, tertiary healthcare, formal, informal health system, who are the healthcare providers within your health system? Is it only the Ministry of Health? Do we have other healthcare providers within the public or private sector? So defining, recognizing, mapping those, and then leading us to better interchange and define the landscape. Now, moving on from defining health systems, and where we relate ourselves to how our health systems are now facing. We're 7 years away from the 2030 and the end of the SDGs. No progress has been made, especially if we're targeting the health-related SDG. Indeed, progress is very slow. And many countries, especially within the global south, unfortunately, will not meet the health-related sustainable development goals. We live in one village now, the globalization and innovation, but we're also challenged by a lot of infectious disease outbreaks, as the recent COVID-19 pandemic that challenged all our health systems, irrespective to where you were at that time, whether in the global north, the global south, all health systems were indeed challenged with this new pandemic. Our health systems are also faced by antimicrobial resistance, which is a challenge indeed to our health systems. We have aging populations in the global north, younger youth population in the global south. We have multi-morbidities, including non-communicable diseases, and indeed gender and inequality is what we'll be focusing and zooming on into during our talk for today. In addition to climate change that has challenged us, so it's no longer the scientists speaking about, well, global warming is happening and climate change will happen, but it's the reality that we're living in. COP29 just ended this November. It was COP28 where finally health had a full day within its discussions. And we're seeing how climate is affecting indeed our livelihoods, our health systems, and unfortunately increasing the gender gap. As Professor Mohammed Al-Mukhayyar mentioned, I'm based at the University of Birmingham in Dubai, in our campus there. And just this year itself, we witnessed floods in Dubai. And we can see how climate change is interplaying. Conflict and war has also challenged our health systems and has yet increased the gender gap within those health systems with refugees, IDPs, and migration. Currently, from the 2nd until the 6th of December, there is discussions around health and migration within the WHO. Urbanization, rising costs, and economic recessions are all some of the challenges that our health systems are faced with. Zooming into SDG 3, good health and well-being. Well, in order for us to achieve it, and we're far from achieving that target, unfortunately, specifically within LMICs, we need to strengthen our capacities of countries at all levels, and in particular, those developing countries, especially in early warnings and risk reduction. And it requires networks to implement it as WHTF and the great work that they're doing at that front. And the pandemic was a reality check, I must say, to the global health community in the need to prioritize and reprioritize health services and indeed how we go around with it. And healthcare workers were evidently a gap that was highlighted during the pandemic, in addition to financial planning and support and risk communication and community engagement, and indeed all the interacting factors that play a role within our complex health systems. So zooming into the SDGs and zooming into how we can further go ahead with this. There's a 10 million projected shortfall in health workers, and in order for us to achieve or to try and bridge the gap in that, more investment in health workers is needed. Now, from a global perspective, let's zoom into the Eastern Mediterranean region and look into the health systems landscape there. So although there's differences, yet there are similarities when it comes to health systems challenges. An example is within the Eastern Mediterranean region, we are indeed 22 countries. We have the 5 high-income countries, the 6 that form the GCC. I'm based in Dubai. The United Arab Emirates, Bahrain, Kuwait, Oman, Qatar, and Saudi Arabia are among the high-income countries. But likewise, we have upper middle, low middle, and low-income countries within the Eastern Mediterranean region. We have challenges, as I had mentioned previously. Climate change is indeed hitting the Eastern Mediterranean region 2 times plus more stronger than predicted. Just last year, this year, that's ending now, the floods in the UAE. Likewise, we had similar floods in Libya. We had the earthquake in Morocco and in Syria and bordering Turkey. So we can see climate change interplaying. The pandemic hit of course, this part of the globe too. There's inequalities and inadequate investment in health systems. And indeed, there is a regional commitment towards universal health coverage, as per the Silala Declaration in 2018 in Oman, where all ministers of health within the Eastern Mediterranean region agreed that indeed universal health coverage is the way to go in order for us to achieve SDGs. So from health systems and defining the global landscape, the regional landscape, now we're zooming into the gender health gap. And what does gender mean? When we refer to it, the characteristics of women, men, girls, and boys that are socially constructed. But we're also looking into the norms, the behaviors, and the roles associated within all these different groups and the relationships between them and the social construct, and varies from society to another, and the change that can happen over time. And just reflecting on our health systems and reflecting on the complexities, but also on how our populations seek their health care, how our social structured and norms are developed, and how they influence the process. So when we mention gender health gap, what do we mean by that? And that's the disparity in healthcare between men and women. And unfortunately, the women's health gap equates to 75 million years of life lost due to poor health equity or early health each year. So these are the figures that we're dealing with, and it can manifest itself in different ways, including access to health care. So it's evident and clear that women are less likely to have access to health care within several settings, being that in less resourced populations, being that due to social norms, being that due to the conflicts and movement, and that affects women and girls to a higher extent. Looking into the quality of care, so women receive a lower quality of care. That's also evident irrespective to where you were geographically. And also when we look into research, where women's health is underrepresented when it comes to research and innovation. So these are all some of the manifested ways in which we look into gender health gap in diagnoses too, in mental health, where women are more likely to experience poor mental health due to all the factors that we had mentioned earlier that are affecting our health populations, and also even when we look at medication side effects. So women are more likely to experience side effects among that. So it's not only within, and we'll zoom into the gender gap when it comes to policy, but it absolutely can manifest its ways within these specific area. Now, you're all probably familiar with this report, where the WHO report highlighting that indeed women are almost 70% of the global health and social workforce. Looking at it from a demand side, from a supply side of the health system, but yet we hold only 25% of senior roles. And as you can see here from the graph, how women are represented in leadership roles within ministries of health, health workers, OECD countries, and so forth. An update to that is, and based on the WHO National Health Workforce accounts, women comprise 67.2% of the workforce globally. But since the data available in 2021 that says that we compromise, so I guess unfortunately we're going backwards rather than forward, and the pandemic has challenged us all, but it showed that women had provided much of the health and care but have not had an equal say in decision making, which indeed is pervasive leadership gap between men and women within the healthcare industry, and looking into the systematic barriers for women's advancement within health, within education, and within the global sector altogether. So there's many reasons for this gender health gap, including subconscious sexism. The medical staff may be subconsciously sexist. This is a reality. The lack of education. Doctors may lack education about women's health, the lack of resources, funding for women's health, and also when it comes to drug dosages and clinical trials that are conducted on men. So it's translated in different forms, and this is just to count some of the reasons. So can we indeed gap what does that mean when it comes to the gender health gap and the economic consequences? So as per the World Economic Forum and McKinsey, investing in women's health could boost the global economy by $1 trillion by 2040. So the gap is evident, the causes are known, and the return of investment is also clearly evident, as you can see here. So how can we close that gap, and what can we do, and based on what we previously mentioned to it. So closing the gap would give us 3.9 billion women in the world today, an extra 7 healthy days a year on an average of 500 days over their lifetime. So it's clearly affecting evidently. And how can we discuss, how can we better close that gap is through addressing these systematic barriers to women's advancement within health systems. Women compromise, and as we mentioned, plus over 60% of the health workforce. Yet as a female health worker, as a medical doctor, then within our health workforce, we find that not many female-friendly environment are set. There's hardship areas that female cannot operate on, especially if they have families. And also their advancement within the healthcare sector would also be hindered due to many factors. The issue of also valuing women's contribution to health, as in the previous slide, within the pandemic, we were relying heavily on health workers, and we were relying heavily on females. They showed evidently their commitment, as we know, as they usually do. But how many of them are in leadership roles, and how many of the voices of women is translated in decisions, in policies? So there's a gap when it comes to female-friendly policies, when it comes to work environment policies, when it comes to bridging the gap in satisfaction of health workers from that end, which is evident irrespective to where women are positioned globally. And also in other advancements, when we look at the gender gap from supply side, improving access to hormone replacement therapy, and increasing awareness of women's health. And that's why WHTF is one of the groups that I indeed cherish, because of the advances, the work, and the support that they are providing to women's health globally, but also encouraging, as I mentioned, workplace support. And we don't find, and we've been advocating for that over the years. How can health systems and health policies be better female friendly? How can the work environment be better equipped. We're finding in many nations and health systems are leaning towards a feminized health workforce. So how can we equip the health system to better their performance, to better their productivity, to better their protection, and to better their education and career pathways? Especially since in many settings, indeed, women form the majority of the health workers, being that as frontline health workers, community midwife, lady health workers, being that also at hospital, secondary and tertiary healthcare level. So how can we better ensure the policies are set in place, our health systems respond to the reality, and that we move towards bridging that gap within health systems and within health policies to better equip our health systems to be more resilient, fit for purpose, and indeed fit for practice when it comes to bridging that gap. So I thought that with that, we're providing food for thought to enjoy a discussion with our participants here today, and better see how we can encourage and advance that collectively as a community within this area. So thank you. Over to you, Mohammed.
Thank you, Dr. Hayat, for your very well done presentation in which you explained all the maybe not all the gap, many of the gaps affecting women, access to health you mentioned, affected by war, quality of care and leadership, research and innovation, and side effect of drugs, and all this what you mentioned, and how to look and how to build a friendly female policy in the future. I would like to ask the participant for their question, discussion, and suggestion. The floor is for the participant, please. Any question?
Hi. Hi, thank you for a beautiful presentation. I was just wondering, I mean, this problem, I mean, this whole gender discrimination, which we have been saying for such a long time and it has been existing. I was wondering, would you have any best practices where when applied the gender health gap has reduced? Are there any such instances? And what would you suggest? We know this has to improve, but do you have any suggestions how to do that? Any practical sort of examples which have happened in your area? Yeah.
Thank you very much. Should we, sorry, Mohammed, should we take all the questions or should I respond?
You can respond. Go ahead.
Okay, great. So thank you for the question. And indeed, in a previous lifetime, I was working with the WHO within the Health Workforce Department that issued the report. It gave us oversight in a way to see how different countries and within different geographical regions, how they respond and react to that. I'm from Sudan originally. And when it comes to, if I could share that experience to at least the pay gap in Sudan, we don't have a gender pay gap within the health workforce. So females and males are equally paid. Irrespective of your gender, depending on your profession. So that's reassurance in a way that there are countries within LMICs that don't discriminate or differentiate when it comes to the pay gap. So that's the payment. When it comes to policies and putting strategies too, in another lifetime, I was also providing technical support for health ministries. And within the Sudan, we have a feminized health workforce, meaning that females constitute nearly 70% in alignment with the global statistics of our workforce. Now, in that sense, what we were working towards was a health in all policy, where health and feminization of health workforce was on the agenda. We were working together with different stakeholders within our health system. And when I started off with the discussion about how you define your health system. So we identified the different stakeholders in health workforce, in human resources for health. And that included, of course, the Ministry of Finance, the Ministry of Labor, the Ministry of Human Resource Development, the Chamber of Civil Servants, to count a few. And through that, we managed to put together a health workforce policy that included feminization, creating more female-friendly, flexible environment, but also not hindering them from what's equivalent to hardship areas. So in many instances, if you serve in a hardship area, there's a bonus to it. So you'll find that men or males within the health workforce get better chances to progress in their career. So what happened was that eventually we find a way that women, for example, within the health workforce can serve in school health, and that's equivalent to serving in a hardship area. Just because they have more tasks. So these are two examples from LMICs, whether it's in a payment perspective or it's in a health system and policy perspective, that together, collectively, through a whole of government, a whole of society approach, we can create that change. It requires a lot of strength, trust, and as you know, working with policymakers and in this interchangeable world that we live in requires a lot of commitment, but together, hopefully we can. Thank you for that. Over to you, Mohammed. Mohammed, you're on mute, sorry.
Thank you for your answer about the question of Kamaini. Here is another question written by Bonita, asking, please, if I may know the determinants of the measurement in terms of the global gaps. Even references thereto will be appreciated.
Great. Thank you for that, and thank you for the question. So absolutely, after this meeting, after our webinar, I'll be sharing with the group the presentation, and in addition to that, all of the references that come with it, whether it being the WHO or the Economic Global Forum, and also a list of different studies that highlight the gaps and where we can address it. So there's different determinants when it comes to the measurement of the gender gap, as I had mentioned, whether we're speaking about social determinants, and within the social determinants, they have their respective measurements, whether we're speaking about geopolitical gap, which interplay also within the gender, the wider gender gap. So there's different measurements, and within the SDGs itself and the different indicators and targets. So hopefully we'll be compiling that and sharing it as a reference, depending on which area we're speaking about, their different measurements that had been used. Thank you.
Thank you, Ayat, for your clarification and answer. Any other question, please?
I'm raising my hand, Mohammed.
Okay, go ahead, Amani.
Hi, thank you, Ayat, for this presentation. I'm happy to meet you. I have personal emotional relation with Ahmed University because I visited it in 1991. That's a long time ago with Professor Zohair Noman, and we met Professor Badri at that time to initiate. So it has a place in my heart, Ahmed University. So I'm happy to meet you. So it looks that the product of Ahmed is great because they graduated one like you. I'm from Egypt, from Suez Canal University, and I'm a doctor. I'm a medical doctor originally too. And in Egypt, as you may know, we have equal payment for women, and the health workforce is mainly women. Okay. And for the leadership, we have leadership. However, however, uh, still the community still do not trust, and there is differentiation between going to a woman doctor and going to a male doctor. Maybe for OBGYN, they will prefer to go to, especially in the rural area. But still, despite that we are widespread and we are now all the medical schools, nursing schools, of course, by profession, are more than half of them are women. Okay, but still the community. So how do you think we can change the community to accept that and remove the gender gap in the community?
Thank you. Thank you very much. Thank you, Professor Mani. It's a pleasure to see you. We met in person in one of the tough meetings previously, so it's
Really?
good to see you today. Yes. I was a student back then, so maybe you won't recognize me.
Yeah.
But thank you for the question. It is indeed, and as I mentioned, it's a change, and we have to a mindset shift. So from the community and back in the day, I'm a strong believer of community medicine and community participation and mobilization. So
Yeah.
evidence has shown within health and in other social harmful traditional practices that mobilizing communities, being closer to communities, understanding their perceptions and understanding how we can better address the issue. So maybe it might be that we from the health from the supply side as medical doctors, as allied health workers are not addressing it in a proper way. So it might be the fact that we sit with communities to get to understand what is wrong or how can we better communication and try and seek from within the communities the champions. Champions always play a role. So if we have role models within the community, being that based on our social structure, if it's within Egypt, I would imagine that absolutely, and there's been great advancements when it comes to FGM in Egypt itself, bringing those social structures that constitute the community, whether it's religious leaders, whether it's respected community members that can create the change within the community to bridge that gap and encourage the community to not only approach but to trust our health systems and I mean it's bigger than gender. It's in many instances also the trust between the populations and the health system. Unfortunately, we lost that trust. So it's bridging that gap, building the trust, and trying different methods and ways in which we can better approach communities, being that through ethnographic studies, understanding more how to cater our messages, and creating the champions from within the communities to lead that change, I guess, is the way to go.
Yeah, I agree with you. I think this starts by the medical education or health profession education. If we educate our students to be immersed in the community, this is challenging to the schools because community is overused throughout years by health professionals. They are taking advantage of it. So the trust is missed. And in the other hand, the physicians or the working health force there is turnover. They are not having long-standing relationship. So it is a real challenging relationship. But I believe always, I'm very optimistic that everything could be solved throughout long last relationship. And the 1,000 miles start by steps, they say. Thank you, Ayat, and I'm happy to meet you. Thank you.
Thank you very much.
Okay, thank you very much, Professor Amani, for your question and discussion. Thank you, Ayat, for your answer. Any more question, please, or discussion or comments?
Yeah, I'd like to.
Thank you, B.
I'd like to change the focus a little bit in terms of talking about the SDGs and the fact that through a gender lens, we have not accomplished, we're nowhere near accomplishing what needs to be done. And your thoughts about how we need to approach things intersectorally and kind of cohesively so that we're not going in with all these individual initiatives that are focused on gender about climate or gender about, you know, water or gender about something else. It seems, I mean, I think it's depressing that we're making, we've made progress in some areas. We are never going to reach the goals. Goals are always supposed to be higher than our expectations, but we should be making more progress. So I just like your thoughts on that.
Thank you, Judy. Indeed, I mean, the challenge is daunting. We're not achieving the SDGs, and now we're already thinking of what after SDGs. So what's the new targets from MDGs to SDGs, now from SDGs to what next? I think the approach would be a health in all approach, a health in all policy. So where when addressing gender and gender in health systems, then it's not upon only the ministries of health to address that. It's not only upon the ministries of social welfare or of labor or of human resource development, but it would start with mapping within our respective health system, within your respective district, area, country, institution, who are the players when it comes to gender and health, and how can we bridge that gap? So bringing all these stakeholders together and starting the discussions, and it was successful in many instances when we came to health systems and health workforce. Many of the challenges were overcome because we brought the different stakeholders to one table. We presented them with the data, with the information, with the evidence, and make sure that it's not only the responsibility of one institution, being that public or private, but that it's a shared challenge, and indeed building that sense of ownership. Now, only with the sense of ownership that in whatever goals we agree on or solutions, we can achieve that through sustainability. Because then you'll find that the officer or the personnel from the Ministry of Social Welfare, it's their mission to end it. So how can we better work together collectively through a whole of government, a whole of society approach, and trying to slowly but effectively embrace that in how we change the way that we develop our policies, our strategies, involving these different sectors and involving the women in the community, because in many instances we sit in our institutions and assume and think that that's the way, but bringing them to the table, bringing their voice within it, and not also forgetting youth and the youth voice within this whole area of gender in this respect, and bridging the gap. So a whole of government, a whole of society approach, and advocating for that will enhance the ownership, the sustainability, and the way forward in doing it collectively. Thank you, Judy.
Thank you, Ayat. Mohammed?
I think he froze.
I think he did too. Godwin commented that he liked the sense of ownership and whole of society approach. There's Mohammed. Okay. So I mean, I think that's a really important part of what you said. Mohammed, over to you. You were frozen.
Hello,
Yeah.
Yes.
can you hear me now?
Yes, we can.
Yes. Any more question, comment, or discussion?
Hello.
Yes.
I was disconnected. Yes, thank you for a wonderful presentation, Dr. Agla. Somewhere you did mention that women are not provided this quality care when they visit the services. And my worry is that most of actually the women are the ones who are visiting healthcare services. Does it mean men get more priority than women, or is it because of resources, or what? Why can't they just be given all what is available, the quality care?
Thank you. Thank you for the question. So it's all of the reasons above that you mentioned. So for example, in some communities, it depends on how communities are structured. And I was working with similar communities where unfortunately women, although they're living adjacent to a health facility, to a hospital, yet they do not reach out to the formal health system, but they reach out to the informal health system. In many instances, it can be harmful, like the use of traditional birth attendants. So that will affect the quality of healthcare services that is provided to them. In other instances, it's the mere fact that also their healthcare seeking behavior differs. So in some communities, women are not given the priority for healthcare and health services. In others, it's that basically health services don't exist, so it's inaccessible to them, the healthcare services, or it's unaffordable. Or the healthcare cadre that provides the health services within that community, for example, is a male, and they prefer female healthcare workers. So it's complex due to this and many other reasons, being social, being cultural, being in many instances conflict-affected states. So when refugees or RDPs, internally displaced people, are within their camps, then healthcare services might not be available in many instances, or to the quality of care that they require. Thank you.
Okay, thank
Do you
you
know?
for your
Yeah, okay.
explanation.
Sorry. Okay. Do you know, Ayat,
Okay, man.
one of my students, one of my students who was conducting a qualitative study about satisfaction of women attending reproductive health care services. One of the complaints that the physicians do not take them seriously, even if they express their problems. They do not take their complaint, and they always refer to anxiety, and they are not taking their time or something like. They do not take the complaint from women seriously. This was also one of the problems that needs to address it in our medical education. That please listen to what she's saying. That's it. Thank you.
Yes, no, thank you for that, and that's evidently reported. Thank you for sharing the experience from Egypt, but likewise, even globally, it's always, and I'll be sharing some of the references and studies in that sense, where unfortunately, when the lady does reach the health facility, that is always referred to as exaggeration to the complaints that they have, and they end up with complications, and in many instances, morbidities and mortalities. So this is the reality that we're living in, unfortunately, whether in the global north or south.
Okay. Any more question? We have 5 minutes to go.
Thank you.
Any comments?
Thank you, Ayat.
Thank you.
Yes.
Thank you very much.
Any
May I
comment? Any
may I
question?
talk?
If there is,
May I talk?
yes, go ahead.
Yes.
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 Yep.
Faiza Hussein from the School of Health Sciences, Ahmad University for Women. Uh, it's nice يعني, seeing you and Ayat. Yes, thanks Ayat for the holistic approach. Are you hearing me?
Yes.
Yes,
Yes.
go ahead,
Thanks so much for the
Faiza.
holistic approach in tackling this gender gap in health from different dimensions. And I'm very pleased because you are going to avail references and maybe I guess statistics about this gap which are missing. This will help us even in talking about the gender gap. We have يعني specific data that can um, enlighten the people about this gap rather than talking about we have gender gap in health, we have gender gap in economics. But this is one thing, and the other thing, I think there is a need يعني, the people in the health sector themselves to know this gap. I think this gap is absent or is in media or in say in the scientific work or what is available for the for the people. But there is a need to highlight this gap, and there is a need to يعني to direct even research in such areas. Thanks so much, and we hope يعني uh, to see this data or references.
Absolutely. Thank you
Thanks.
very much. Thank you.
Mohammed, Nafisa has her hand up. Nafisa.
Yes,
Yeah.
Nafisa Bedri,
Yeah.
welcome, Professor Nafisa Bedri. And also, I would like to welcome Dr. Faiza Hussein from Ahfad University for your participation. Nafisa, the floor is yours.
Thank you, Dr. Mohammed. Thank you, Ayat, and it's always good to see you. And thank you for a very comprehensive and very interesting presentation. One of the things I wanted to highlight, and you mentioned some of it about the issue of social determinants of health and health-seeking behavior. And I think one of the things that we don't usually take into account when we do our research or when we analyze these social determinants using different frameworks and theories is how women theorize or develop frameworks themselves to assess the quality of care they receive. And I'm just going to give a very quick example. When I was doing my PhD on health seeking behavior for perceived abnormal vaginal discharge among women in Omdurman, in Sudan, the women told me about the different aspects that they use to assess the quality of care they receive because they consult with their social network before choosing a provider. And then the social network, they tell them that if you go to Dr. X, he's going to do, for example, a urine test, vaginal examination, and then he's going to give you a red and blue pills to take. So for her, these are the elements of quality of care. So when she goes to the doctor, if the doctor does anything different from these four elements, then this doctor will be evaluated as an unsuitable one. And then he will not be visited again by any of the women in her social network. So we need to understand how these elements work in helping women to access care, but also on how they actually uh, compose these frameworks themselves within their agencies, and they use them in order to access care. So it's not always just the common causes of the transportation and the mobility and the cost and the healthcare providers' attitudes, but sometimes it is the package of indicators they come to visit the care with. So it is something that maybe in future when people are developing new indicators, as you said, for the coming, we don't know SDGs, MDGs. We should think about this element. Thank you very much, Ayat, again, for a very comprehensive presentation. Thank you.
Thank you, Professor Nafis. It's lovely to hear your voice. And indeed, the healthcare seeking behavior and understanding how our communities operate within their respective socio-demographic structures is key in advancing any gap provided. Thank you.
Okay, any more question? Because we are approaching our end of the session. If no question, I would like to thank Dr. Ayat for this very elaborative and constructive presentation. Well done. Wish you all the best and hope to see you in the near future for another webinar. All the best. Goodbye to everyone.
Thank you
Bye.
very much. Thank you. Goodbye.
Bye.